Hi, welcome to this lecture in Basic Science in Orthopedics, and in this lecture we're going to speak about genetics in orthopedics. A good source that you can use is this book written by myself. In the next two slides we're going to speak about systemic disease that has musculoskeletal manifestations, the most common of them, and what are the genes that is responsible. Osteogenesis imperfecta, the gene affected in this disease is the collagen 1A1, which gives the type 1 collagen. Achondroplasia, it's fibroblast growth factor receptor 3, and remember it's the fibroblast growth factor receptor. Sometimes they get the answer without the receptor, so it is not going to be correct. So it's the fibroblast growth factor receptor 3. Marfan syndrome is the FNB1, which is the gene which codes for the fibrillin protein. So Marfan syndrome is due to a problem with the fibrillin protein. The gene which is responsible for that is the NFB1. Dystrophic dysplasia, the gene responsible is the sulfate transporter gene, which is responsible for the proteoglycan sulfations. It's called DST. So it is the gene responsible for the sulfate transport. In pseudoachondroplasia and in multiple epiphyseal dysplasia, both have the same gene affected, cartilage oligomeric matrix protein, COMP protein. That's why pseudoachondroplasia, there is affection of the cartilage. That's different from the achondroplasia, which does not have affection of the cartilage. Remember, both pseudoachondroplasia and multiple epiphyseal dysplasia have the same gene. Spondyloepiphyseal dysplasia, it's the gene responsible for type 2 collagen. Duchenne muscle is the gene responsible for the dystrophin. Remember also Baker's muscular atrophy is the same gene. The difference between Duchenne and Baker is the amount of affection. If there is more affection, it's Duchenne. If it's less affection, it is Baker, but they are both the same gene. Fibrous dysplasia, it is the GS alpha gene, which is the receptor for the coupled signaling protein. It's called GNAS1 gene. This is, or sometimes comes with the GS alpha. Fibrous dysplasia commonly come in the exam. What is the gene affected in it? So it's the GS alpha. Osteopetrosis, it is the carbonic anhydrase type 2 proton pump. So the gene that is responsible for the carbonic anhydrase type 2 proton pump. So it's mutation of CLCN7 or TCIRG1. For multiple hereditary exostosis, there is two genes, EXT1 and EXT2. This is frequently come in the exam. Please note that patients who have, due to mutation of the EXT1, usually have a disease that is more manifested than those who have the disease due to EXT2. Neurofibromatosis type 1. This is due to affection of the NF1 gene on the chromosome 17. Sometimes you ask in which chromosome, it's 17. Charcot-Marie-Tooth also is a gene on the chromosome 17. However, the gene is peripheral, is the gene that codes for the protein PMP22 or peripheral myelin protein 22. Spinal muscular atrophy is due to affection of the survival motor neuron protein gene. More diseases here also with the genes affected. Turner syndrome. Remember, Turner syndrome is not a genetic disease. However, shortening that happens with the Turner syndrome happens due to the gene short stature homobox gene. Vitamin D dependent rickets type 1. This is due to the 25-hydroxy vitamin D hydroxylase gene. Cleidocranial dysplasia, this is due to SBFA1 or RUNX2. These genes, of course, responsible for bone formation, and we're going to speak about them. Apert syndrome. Apert syndrome, it's a disease that affects the hand. So sometimes they will give you a picture of a mitten hand and affection of also the skull by the sutures in the skull, early fusion. It is due to fibroblast growth factor receptor 2 genes. Why this is commonly come in the exam? For two reasons. Because they can give you pictures, they don't have to tell you the name, And the other thing is it is very close to the achondroplasia. So it is not 3, it is 2. X-linked hypophosphatemic rickets due to the PEX or PHEX, Friedreich's ataxia due to fraxitine gene, club foot. There are some genes associated with the club foot, mainly ITX1 and TPX4, fibular hemimelia, sonic hedgehog gene, and fibrodysplasia ossificans progressiva. It is activin A receptor type 1. Sometimes they will give you also an X-ray of exuberant calcification, like in the shoulder, with a calcification of basically most of the muscle around the shoulder, and they will ask you what is the basis of that. It is due to affection of the gene activin A receptor type 1. So this is one of the commonly asked questions in the exam. Now, after we talked about the gene, let's talk about the pattern of transmission or modes of inheritance. Mainly there are 4 types: autosomal dominant, autosomal recessive, X-linked recessive, and X-linked dominant. Most of the autosomal dominant are structure abnormalities. The common disease that affect the musculoskeletal is the multiple hereditary exostosis. As you remember, we said it's due to EXT1 and EXT2. It's an autosomal dominant disease. The metaphyseal dysplasia, the pseudoachondroplasia, the spondyloepiphyseal dysplasia congenita. So the dysplasias here are due to autosomal dominant. Marfan is autosomal dominant cleidocranial dysplasia. We talked about this when we discussed the genes. Multiple epiphyseal dysplasia. So as you can see, also achondroplasia. So most of the dysplasias, which are structural abnormalities, are autosomal dominant. Neurofibromatosis type 1 is also autosomal dominant. Fibrodysplasia ossificans progressiva. As I told you, you will get a picture of exuberant calcification around the joint, and you will be asked what is the gene or what is the inheritance. It's autosomal dominant. Autosomal recessive. Autosomal recessive usually due to enzyme abnormality like the homocystinuria or the hypophosphatasia. Dystrophic dysplasia is autosomal recessive, so we know most of the dysplasias are autosomal dominant, but the dystrophic dysplasia is actually autosomal recessive. Mucopolysaccharidosis, except the Hunters, are all autosomal recessive. Vitamin D dependent ricket, dependent, not resistant, is autosomal recessive. Sickle cell disease, it's autosomal recessive, and if you have one gene, it will be called a sickle cell trait. X-linked recessive, like the hemophilia A and B, they affect, of course, the joints. They cause repeated bleeding, which can cause arthropathy. Duchenne, Duchenne is frequently encountered disease in orthopedic. They get equinus, also they get scoliosis, so you need to know the Duchenne. Hunter, we said all the mucopolysaccharidosis except Hunter are autosomal recessive. The Hunter is X-linked recessive. And spondyloepiphyseal dysplasia tarda is recessive. We said the congenita is dominant, but the tarda is recessive. X-linked dominant, as I said, the X-linked dominant disease are not frequent, so they frequently ask it in the exam. The one that you need to know is the X-linked vitamin D resistant ricket. So it's a vitamin D resistant ricket, or sometimes called the hypophosphatemic rickets. The pseudo-hypoparathyroidism is also X-linked dominant, pseudo-hypoparathyroidism, and Lewy dyschondrostosis. So these are the X-linked dominant. So X-linked dominant, the disease that are X-linked dominant are not many. That's why they come frequently in the exam. Most important is the X-linked hypophosphatemic rickets, or sometimes called X-linked vitamin D resistant ricket or hypophosphatemic rickets. Pseudo-hypoparathyroidism and Lewy dyschondrostosis. The process of osteoblast differentiation from the mesenchymal cell is very complicated process, and there are some genes involved in this process. One of them is the RUNX2 or the core binding factor alpha, CBFA1. And if you have an affection of this gene, as we said in the table in the beginning, for the musculoskeletal disease that are due to genetic defect, you will get cleidocranial dysplasia. So you see here this X-ray, this patient has a cleidocranial dysplasia. There is an absent clavicle here, so there is no clavicle, as you can see here. So this is cleidocranial dysplasia, and it is due to affection of the RUNX2 or the CBFA1 gene. Another very important process in the osteoblast differentiation is the Wnt protein. The Wnt protein activates the lipoprotein receptor related protein 5-6. It's called LRP5 and 6. When the Wnt protein bind to the LRP5 and 6, what happens is there will be an increase in the unphosphorylated beta-catenin. As you can see here, this will stimulate the unphosphorylation of beta-catenin, so the phosphorus will be away from the beta-catenin, and the increased beta-catenin, unphosphorylated beta-catenin, will result in activation of the osteoblast. So this process of the Wnt protein binding to the LRP5 and 6 again will result in increase in the unphosphorylated beta-catenin, which will result in stimulation of the osteoblast function and differentiation. There are two proteins, the DKK1 and sclerostin. These inhibit this process. So these two proteins, the DKK1 and the sclerostin, will result in inhibition of this process, which will result in inhibition of osteoblast differentiation. Now there are some trials of medications which actually happens to block these two proteins, the DKK1 and sclerostin, from doing its function. So when you have an anti-sclerostin protein, this will result in the Wnt protein doing its function. This will result in osteoblast differentiation and function more. So this anti-sclerostin protein can be used for treatment of osteoporosis. One of these anti-sclerostin protein is called plusozumab. Plusozumab is an anti-sclerostin protein, so it will inhibit the sclerostin and DKK1 from inhibition of the Wnt protein. So again, Wnt protein bind to the LRP5 and 6, result in increase in the unphosphorylated beta-catenin, will result in osteoblast differentiation and increased function. Two proteins inhibit this process, so when you inhibit these two proteins, you will result in increased function. The protein that inhibit these two proteins from inhibition of the Wnt protein can be used in treatment of osteoporosis. One of these antibodies is the plusozumab, and it inhibits the sclerostin, so it allows the Wnt protein to do its function. We spoke at the beginning of the lecture about fibrodysplasia ossificans progressiva, the FOP. We said it's an autosomal dominant disease, and it's almost always due to defect in the ACVR1 gene. This defect will result in altered BMB4 signal. When the BMB4 signal is altered, actually you get increased ossification. So the mutation in this gene, the ACVR1, will result in altered BMB4, and this altered signal will result in increased ossification. You may get questions on this disease, the fibrodysplasia ossificans progressiva. You may ask mode of inheritance. It's autosomal dominant. What is the gene? ACVR1. What is the mechanism? It's altered BMB4, which will result in actually increased ossification. Sometimes they don't tell you the name of the disease. They get you a picture for a newborn with the big toes. So remember, one of the characteristics of the fibrodysplasia ossificans progressiva is the patients will be born with big toes. So you get a picture, for example, for a shoulder with increased ossification, and then picture of the foot with deformity of the big toe. It will ask you what is the gene responsible. It's the ACVR1 gene. What is the mechanism? It's altered BMB4, this which will result in increased ossification. Regarding the cartilage development, one of the most important gene is the SOX9, and this is involved in the chondroplast differentiation. So it's, SOX9 is the gene involved in the chondroplast differentiation and chondrocyte lineage. Thank you. I know that this lecture is hard and there is lots of things to remember, but putting them together sometimes makes it easier, and I hope you the best in your career and exam.